Good evening, ladies and gentlemen. Thank you very much for joining us on this Friday evening. My name is Suvir Venkataraman. I'm the manager at Harley Street Fertility Clinic, and I have the pleasure of presenting tonight's webinar, which is titled Choosing the Best Embryo. First, I would like to introduce our esteemed panel. So joining us this evening, we have Dr. Geetha Venkat, who's the director of Harley Street Fertility Clinic, and the clinic's embryology lab manager, Miss Samantha Knight. And this evening's agenda will cover embryo culture and development, and morphological assessment and grading of embryos, as well as time-lapse culture and morphokinetics. And then we'll look at testing of embryos for aneuploidy, as well as some thoughts on how we might improve embryo quality, and then how this all fits in as part of treatment, if you're looking at it from that point of view. So now I'd like to hand over to Dr. Venkat to get us started. Thank you very much.
Thank you very much, Suvir. Thank you, ladies and gentlemen. So we are going to talk about the chances of success with the treatment, how we can maximize your chances. So the aim is to choose the best embryo for transfer, and that way we'll give you the best chance of success. As you are aware, the Human Fertilization and Embryology Authority has guidelines for the IVF treatments throughout the UK, and it says that as far as possible, we should recommend single embryo transfer for women under the age of 40. And if someone has had previous cycles or other extraordinary conditions, then we can transfer 2 embryos if it is needed. If we are going to replace one embryo, then it is better to choose the best embryo and the right embryo. These are the words we must remember. How do we select that? Then we go by the grading as well as the testing. So my colleague Samantha will tell you more about it. I am going to now talk to you about how we are going to create the embryos. So we take a couple, the man will produce the sample, which will give us the sperm, and the woman will extract the eggs from the woman, that is IVF treatment. And then we will prepare the egg and the sperm in the laboratory, and we call it mixing. That is, in laboratory terms, we call it insemination of the eggs with the sperm, and we leave it. Next day, the embryologist will come and look at it to see how many embryos have fertilized. And now we have what is called the time-lapse embryoscope, where we can place the embryos and we can see them develop without taking the embryos out, so that we don't disturb them, and that also increases the chances. That is one way of making the embryos do better. Now, in some cases where the sperm is not good enough for IVF treatment, that means just mixing the sperm and the egg, we have to use the technique called ICSI, that is intracytoplasmic sperm injection. There, the sperm needs extra help. And you might have seen this picture in all the television programs where they talk about IVF. Actually, what they show is ICSI, that is ICSI. And where you can see that the needle is being passed into the egg. The round structure is the egg, which is fixed by the pipette on one side so that it doesn't keep moving. So if you have a moving target, it's more difficult. So we fix the egg first, and then we introduce the needle. Now we must remember, we must have that needle will have, or it's called injection needle, ICSI needle. It will have a sperm inside. So the embryologist would have taken the sperm from the dish and inject the sperm into the egg, and then they will withdraw the needle, leaving the sperm inside. They will withdraw the needle. That procedure is called, as you can see here, intracytoplasmic sperm injection. Therefore, the difference between IVF and ICSI is here we leave the sperm outside the egg and allow the sperm to get into the egg or penetrate the egg and fertilize the egg. Whereas in ICSI, we put the sperm inside the egg, Therefore, we give extra help to the sperm, and once it's placed inside, it will fertilize the egg. This is called ICSI. Now, if we do have a lot of abnormal sperm, it will be difficult to put the right sperm inside. Again, for any treatment, any success rate, we must have the right egg and right sperm is said. And if we have to put the best sperm to get the best result, we have to select the sperm. With the ICSI, what we are doing is injecting the sperm. And before that, I said we should take the sperm into the needle before injecting into it. How do we do that? So we have to select the sperm using a more powerful microscope. And that procedure is called, or that process is called intracytoplasmic morphologically selected sperm injection. In short, we call it IMSI or IMSI. If you want to learn more about it, you can look at our website, and there also you can Google it, and Dr. Google will help you with that. And so here we are able to see one sperm in a higher magnification, and in the sperm head, which is like little conical shape, you can see vacuoles. And embryologists don't like the sperm which has got lots of vacuoles. Sam will tell you more about it. And they want to choose the sperm with minimal vacuoles or no vacuoles. That is supposed to be the best sperm. So to select the sperm, IMSI procedure is helpful. And to inject the sperm, we have to do ICSI, that is ICSI. So these two processes or the procedures are usually combined in cases of the sperm issues. Okay, so now we are comparing these two procedures, basically, the IVF versus ICSI and IMSI. Now, all these procedures are called in vitro fertilization, because fertilization happens in the lab, not in your body. Things you want the fertilization to happen inside your body, that is treatment like IUI or natural trying. But here everything happens in the lab. However, the IVF is said to be more natural because we put the eggs and the sperm together, and the sperm goes and penetrates the egg, fertilizes the egg naturally. Whereas in ICSI, it's more invasive, and we inject the sperm into the egg. So that's what you see, that here requires sperm to fertilize and good quality and not suitable for eggs that are frozen. Here, like I said, it's more invasive. And one more thing with ICSI is that we cannot inject immature eggs. So even with the IVF, immature eggs will not fertilize. However, because we are leaving in the dish, it allows the eggs to mature in a couple of hours, few hours time, and then that egg can be fertilized. Whereas ICSI means the egg has to be mature at the time of the injection. And we use it when the sperm quality is suboptimal. And eggs which are frozen, they cannot fertilize with IVF technique. So the sperm has to be injected. So any egg which is frozen needs ICSI. And we talked about IMSI. Here we want to select the most normal sperm or better sperm fertilization. It only disadvantage, it takes time. And like we said, we put it under intense light, and which can damage the sperm a little bit. Of course, the experienced embryologists, they do it very quickly. It only takes a few seconds, but even then, it is not a great thing. Now, we are going to look at the picture of the embryos. Sam, am I passing it over to you?
I believe so, Dr. Venkat. Thank you.
Thank you.
Okay. So we obviously fertilize the eggs using either IVF, ICSI, or IMSI, as described by Dr. Venkat. And we call the day of the egg collection, and when we mix the sperm and the egg, day 0. Then we look at to do with embryos basically every 24 hours. So 17 to 19 hours after we've mixed the sperm and the eggs together. On day 1, we look for fertilization. So we look for 2 pronuclei, one from the sperm and one from the egg, to say that an embryo or an egg has fertilized normally. Then 24 hours after that, on day 2, we look for 2 to 4 cells. And the picture on the screen shows that. Okay. On day 3, we look for 6 to 8 or 10 cells. Optimally, 6 to the 10 cells. Sometimes it can be a full cell. And then on day 4, the cells are numerous and too many to count, and they start to compact, and it's something we call a morula, and it's very hard to judge how an embryo is developing on that day. That's why there isn't a picture. On day 5 and day 6, the embryo sort of differentiates into a blastocyst, and we have 2 different parts. As you can see, there's a ball of tight cells in the middle, and then there's lots of scallop cells around the outside. Okay, and we call the ball of cells the inner cell mass, and we call the scallop cells the trophectoderm. Some embryos will stop growing between day 3 and day 5 and 6, and it's almost like self-selection. So the strongest embryos make it to the blastocyst stage, and that's why embryos at a blastocyst stage have a higher chance of achieving a pregnancy than those on day 2 or day 3. Okay, so as we were describing, you can see the very tight ball of cells which goes on to develop into the fetus, which is the inner cell mass, and the trophectoderm goes on and becomes the placenta. So we have a grading system for that, which I believe we can talk about slightly later on. Or also blastocysts can have different developmental stages. They go from being an early blastocyst to a full blastocyst to expanded to hatching and hatched. And it's when a blastocyst hatches out, it implants and achieves a pregnancy. So when we're grading embryos, we're looking for several things. We're looking for the kinetics, so we're looking for the number of cells at the right number of hours post egg collection. So we're looking for 2 to 4 cells on day 2 and 6 to 10 cells on day 3. And we hope to get a very nice full blastocyst at 120 hours on day 5. Okay, we're also looking for the symmetry. So at the cell stage at day 2 and day 3, we're looking for the cells to be even if they're at 2 cells and 4 cells. And we're looking for them to be slightly uneven at 5 cells or 7 cells or 6 cells. So they're graded in a stage-specific manner. We give them 2 numbers at the cellular stage. And the first number is the evenness. And the second number is the degree of fragmentation. All embryos will have fragmentation, and we score that on a percentage basis. We also look for the appearance of the cells to see whether they are clear as opposed to being grainy. And we also look at the development pattern when we select the best embryo to check that it has made the right cell stage on each day of its development. So we look at the whole picture when we're choosing which blastocyst to transfer. So here we've got 2 videos that Suvir will play in a moment, which is taken from an embryoscope. That's time-lapse culture. As Dr. Venkat said, the time-lapse culture helps us to make decisions as to which embryo to go back, both on the kinetics and the development. And it also allows us not to disturb the embryo, so we don't have to take them in and out of the incubator. Basically, it's a camera inside an incubator that can view the embryos without disturbing them, and therefore giving them a greater chance of achieving a blastocyst stage because we're not having variations in temperature or pH. And it also gives pictures every 15 minutes, 24 hours a day. So we can play it and we can look back and see how the development is and look for any unusual behavior in that pattern, as well as being able to see if they behave according to the timeline that they should. So it's a very useful tool. and it helps us make an assessment as to which embryo to put back. So Suvir's going to show you the first video. So this is of a good quality blastocyst. You can see there's degrees of fragmentation there. And you can watch it go from 8 cells. And then it compacts into a morula. And then it starts to become a blastocyst. So you can see that there's a nice pool of cells for the inner cell mass, and there's lots of scallop cells for the trophectoderm. And then Suvir's going to play you one that is a slightly poorer quality embryo. So you can see at the beginning there's some graininess in the center. And you can see again there's some fragmentation. And it begins to become a blastocyst, but you can't clearly see an inner cell mass, and there isn't a lot of scallop cells in the trophectoderm, which goes on and forms the placenta. Okay, so the advantages of time-lapse over a traditional incubator and culture system is, to recap, they're not disturbed. They have a photograph taken every 15 minutes, so we can see any changes that occur. So things traditionally were looked at under a microscope once a day, whereas this monitors the whole progress of the embryo. So you can see things like reversing in cells. So you may have an embryo at an 8-cell stage, and it may reverse to being a 6-cell and then going on to being an 8-cell, which would not be your first choice of embryo to transfer. They also allows continuous development, so to be monitored, so we can see what's going on in that embryo. And it allows us to monitor the time that the embryo develops against a timeline. So we know that an 8-cell is at the correct time, and we know that you have a blastocyst at 120 hours. I believe I'm handing over to Suvir at this stage to talk about euploidy and aneuploidy.
Thank you, Sam. So now we've found out what looks like a good embryo, but is that going to result in a successful pregnancy? Well, there's a bit more of the story that we can explore. So as most of you are now sort of quite familiar with DNA, or what it is, so DNA is our genetic material that gets passed down, and it's in all of our cells. So all of our cells should have a complete copy of our DNA. And the DNA is arranged into 23 pairs of chromosomes inside the nucleus of each cell. Now, when it comes to embryos, the embryo can look great, as you might have just seen on, the embryo under the microscope, or in an incubator or an embryoscope, but it might not have the right number of chromosomes. So why is this a problem? So if embryos don't have the right number of chromosomes, they won't develop normally. So that means either they won't implant, or if they do implant, they might miscarry, or worse, they might actually go on to cause a stillbirth or lead to a child with a severe disability. And we really, that's what we're trying to avoid. We want a healthy baby at the end. So how can we check before we transfer embryos? So we can count the number of chromosomes. So the correct number of chromosomes inside any cell is called the euploid number. And for humans, that's 23 pairs. So when a cell doesn't have the right number of chromosomes, it's referred to as aneuploid. And what we can do is actually take a sample of each embryo and check whether or not that embryo has the right number of chromosomes, or whether the cells that we've sampled have the right number of chromosomes. And that gives us an idea as to whether the embryo itself is genetically normal, essentially, or has the right number of chromosomes. Now, why is this important? Well, there's an astonishing number of embryos that we create that are aneuploid. They don't have the right number of chromosomes. And unfortunately, this increases with maternal age. So there's a graph on the right-hand side which shows the number of aneuploid blastocysts, so the number of abnormal blastocysts that are created, and that varies with maternal age. So when someone is under 35, you can see that the number of normal blastocysts created is just under 50%. Now bear in mind, not all embryos even reach the blastocyst stage. So we're already looking at the best embryos that are produced in an IVF or ICSI cycle. And out of those, only half of them are actually euploid. So only half of them can result in a healthy pregnancy. Now, as you go up to, say, 41 or over 42 years, that reduces to just about 20%. So if you have 5 good quality blastocysts, which is quite unlikely in a woman of that age, only one of them is likely to be euploid, i.e. has the right number of chromosomes. So it sort of highlights the importance of testing, particularly in patients who seek fertility treatment, because most of them tend to be a bit older. And so this becomes more and more important. I do need to point out that there is a small risk of damaging the embryos when we biopsy them, when we remove that sample, which is less than 1%. And the other point I need to make is that this testing of embryos, which is referred to as preimplantation genetic testing, or PGT, and it's preimplantation genetic testing for aneuploidy, so it's referred to as PGT-A. It's currently classified as a treatment add-on that the HFEA don't take a favorable view on, because there is a lack of a randomized controlled trial for the efficacy of this particular technique on pregnancy and miscarriage. However, there was a randomized controlled trial in older women using this technique for clinical outcomes, and it showed better clinical outcomes in older women. So it's women aged 38 to 41 had better clinical outcomes when PGT-A was performed in IVF cycles compared to when it wasn't. So now this slide has quite a lot of interesting information on it. The first graph on the left shows the live birth rate per egg collection with and without PGT-A by age group. So the pink bars are without PGT-A and the blue bars are with PGT-A. Now you can see that the blue graphs are always significantly higher than the pink ones. That means generally if you perform PGT-A, the chance of having a live birth per egg collection is higher. But what's more interesting is actually if we look at the live birth rate not per egg collection, but actually compared per embryo transfer, i.e. out of the number of embryo transfers that we do, how many result in a live birth. What's really interesting here is that the drop-in rate with PGT-A cycles, so the difference between the blue bars is not that different. So the drop from someone under 35 to someone over 42 when we do PGT-A is not very much, compared to when we don't perform PGT-A, the drop from someone who's under 35 to someone who's over 42 is very large. Why is that? So this is because what we're seeing here, what's causing the drop is essentially the miscarriage rate. And so if you look at the final graph on the right, it shows something very interesting. It shows that the miscarriage rate when we don't perform PGT-A increases significantly in women as they get older. However, when we perform PGT-A, we can reduce that increase in the miscarriage rate quite considerably. And those of you who are sort of paying attention quite closely will then ask the question, how is this achieved? Well, one of the problems is that This means every time you have an egg collection, you might not have any embryos that are suitable for transfer because all the embryos might be aneuploid. However, what it does mean is that when we do transfer an embryo, we have a much better chance of that embryo implanting. So now I'd like to hand over back to Dr. Venkat, who will talk to you about improving embryo quality.
Thank you, Suvir. Okay, so we have now so far concentrated on the methods and embryo grading and how we make the embryo grading and testing the embryos. So what do we need? We need one embryo which is of very excellent quality and containing normal chromosomes. That is assessed by the preimplantation genetic testing. How can we do that? So we must have the best egg and the best sperm. So the couples who come for treatment, usually they produce the man or the male partner produces the sample, we prepare the sperm and use it for fertilizing the eggs. So the quality of the embryo depends on the quality of the sperm and quality of the egg. Okay, so we are making the babies with the material you give us. Therefore, it's important that you give us the best material. How do we do that? We are all eating food and our body is made up of the food we eat. So it is important for us to eat good food. Everybody thinks that we are eating good food. Like if you ask me, I'll say, oh, I always have good quality food, balanced diet. No, sometimes we don't. We don't focus on the things we are eating. We are so busy in life. We are rushing around, especially now with the lockdown, it's not so bad. But generally, we are rushing from one place to another. We have appointments all the time. We don't have time to cook. So it's important you focus on what you eat. Avoid all the, I wanted to say junk food, but I should not say that. I wanted to say, look, all the processed food is not good for you because it contains all the chemicals. We don't want that. We want a natural food. Eat lots of fruits and vegetables. Drink lots of water because 70% of the cell content is made up of water. Every cell in our body contains 70% of water. So you need to drink water. Then only you can function efficiently. And changing lifestyles, doing regular exercises, eating well, and sleeping, so say 8 hours or 7 hours, whatever you need, because only during growth your cells and tissues rejuvenate. All these things are important. Those people who smoke and drink and using recreational drugs, they should reduce all these things. And these things will definitely improve your general health and the quality of the eggs and quality of the sperm in the case of men. So these are the basic things. Like I said, if we want to get the good quality egg and good quality sperm to make the best embryo. But there are some clinical things we can do to help you improve your quality. So that is basically in the form of stimulation. And your clinician, whichever clinic you are going, will look at your hormone profile and the proportion ratio of one hormone to another and your AMH level and your body weight and decide which protocol should be used, what medication should be used. Every little thing is important. You can't just casually say you start some hormone, it will be fine. It is not. Every attention to detail is the key to success. Therefore, we'd like to say what protocol, what medicine should be used for stimulation. All these things will have an impact because if the eggs are not good, Samantha will come and tell me, you're not doing the right protocol. You're not doing the right stimulation. So we are all very careful looking at the charts every day, and also the scans. The nurses will come and say this is not going well. So the whole team will concentrate on that. What else can we tweak? One of the important things I would like to mention is called growth hormone. There is, of course, controversy about it. There are studies which say that it increases the live birth. but there are some studies say that it has got no effect. However, in women over the age of 40, especially with reduced ovarian reserve, this growth hormone is supposed to be helpful, helps with the growth of the follicles and make us get more mature eggs. And they have done some studies where it's shown that people who use the growth hormone have a higher live birth rate compared to the group where the growth hormone was not used. Therefore, if we can produce 1 or 2 more babies, I think it should be recommended, because that makes the difference for that woman. And that is the place of the growth hormone in improving equality. And another clinical factor or laboratory factor which we consider in such cases to improve the quality is the oocyte activation. This is to improve the calcium channels in the egg or the oocyte, where when the egg is sort of old or from an old woman, say over the age of 38 or 40, the quality of the eggs goes down. So the calcium channels are not activated so well, and therefore the fertilization is impaired. So we have low fertilization rate, or sometimes we have no fertilization at all when we perform the ICSI. Because when we inject the sperm, we expect the sperm to activate and then start the fertilization to occur in most of the eggs, not 100%, but most of the eggs. Sometimes we see, in spite of injecting the egg, there is not a single egg which has fertilized. In such cases, we have found that this calcium oocyte activation will be helpful, and you will have more embryos, and that is because it improves the quality or it helps in the fertilization. However, we should be aware of the chromosomal abnormalities, the embryo abnormalities, which could be increased because of this process. That's why we say it should always be combined with embryo testing or preimplantation genetic testing. So this is one of the factors. And so I talked about the eggs so far. Now we go to the man, because we should never forget the male side. Usually the male partner is ignored in the fertility clinics, but we can also do something for them. What do we do? Supposing somebody has got a low sperm quality and the fertilization is not good, or the quality of the embryos are not good, how do? We say that we can do what is called PISA, TISA, percutaneous epididymal sperm aspiration or testicular sperm. In this case, actually testicular sperm aspiration. That means we take the sperm directly from the testicles. And that sperm is supposed to be better. That's called surgical sperm retrieval. Why is it better? Because we go to the source directly, not depend on the sperm which is coming out. What happens is the sperm which comes out through the tube, during its journey, it is exposed to oxidative radicals. So, and the sperm gets, sort of is not able to function well. The quality deteriorates during its passage through the tube when it comes out. To avoid this problem, supposing we give the men antioxidants, we ask them to take it to improve the quality of the sperm. Still, if it's not improving, the best thing is to go to the source so that the sperm is not exposed to these oxidative radicals. So it is the authentic, pure sperm, we get it, and it's supposed to improve. And there are papers which say that it improves the live birth and success rate with the treatment. Our aim is to maximize the chances, and that's what we are aiming to do. So basically what we are trying to do is get the golden egg, golden sperm, make the golden embryo, which is going to give you the baby. Of course, it depends on you, because you have to give us the golden egg and golden sperm, and we'll make the golden baby for you. So that's how I think everyone has to do everything that is possible to increase the success rate. So the couple gets pregnant in the shortest time and go home with a healthy baby. That is the aim of this whole topic today. Okay, so now I'll just go through the pathway for you. So you might be wondering, so we are talking about the choosing or selecting the embryo, making the golden embryo. What happens? Where do we start? So it's a long process. First of all, you need to come and see the consultant or the doctor in the clinic. They will go through the history. I know we will ask you boring questions like when did you have your period? How long is the period? All these routine questions will be asked again and again, but we get all the important information about the patient. This will be helpful for us to plan the treatment. After the consultation, the doctor will arrange tests, which will be like a basic fertility checkup, which includes an ultrasound scan between the 2nd and 5th day of the period and blood tests at the same time. This will tell us about the ovarian reserve. So in the scan, we look at the uterus and the ovaries to look at the number of eggs, and the blood test also tell us about ovarian reserve, ovarian function, quality of the eggs, and other hormones related to this ovarian function. After this initial test, then a follow-up consultation will be arranged with the doctor, who will discuss the results with you and the implications of the result. Supposing everything is fine, then we don't have to worry about it. Both sides, the female test and the male test, are normal. And if you have been trying for some time, the doctor will discuss with you all the options available by simple methods. And then if it does not work, then you can step up. And we also make a diagnosis. Is it a case of tubal factor or male infertility, or is it a case of unexplained infertility? You might think that if everything is all right, why I'm not getting pregnant? That category is called unexplained infertility, which is present in 1/3 of the couples. So we will find out the cause. But in some cases, if we find some conditions such as tubal factor, when the tubes are blocked, then the sperm and the egg cannot meet, we have to perform IVF. Or if there is a severe male factor, we have to perform IVF. Or if there is severe endometriosis, it will be IVF. And so the doctor will discuss with you the various options. And if you need IVF, the doctor will plan the IVF. So the IVF treatment involves preparation, stimulation, and monitoring. So what is involved in the preparation is you have to do the basic tests like screening tests to check for any infection. And then we will also prime the treatment with some progesterone tablets. The idea behind this is to make the cohort of the follicles grow together so that they mature together. This avoids scattering of follicles during the stimulation. After this preparation, then the woman starts with the hormone injection for 10 to 12 days, during which she will have monitoring with regular scans and blood tests to check the hormone levels. Depending on the ovarian response to the stimulation, hormone stimulation, the dosage of the hormone medication will be adjusted, and we avoid hyperstimulation, and similarly we avoid very poor response to stimulation as well. And at the end of the stimulation period, the follicles will be mature. Then the consultant will plan the egg collection procedure, which you can see the picture here. I have been using this picture for the last more than 25 years, but this has not changed at all, I can tell you, because the procedure is the same. This is done under ultrasound guidance, and there will be an anesthetist who will give conscious sedation. That means he will give you anesthesia intravenously. However, you will be conscious during the procedure, but don't worry, you will not feel any pain during the procedure. So by aspirating the follicles, we pass the fluid to the embryologist, who is Samantha, sitting next to me in the lab, and she will identify the eggs, and then she will start shouting 1 egg, 2 egg, 3 egg, and we are happy to hear this number going up. And once we finish the one side, we do the other side, we collect the eggs, and then we keep the eggs in the incubator. After this, we then fertilize the eggs either by IVF or by ICSI, which I explained earlier. Then you can see they become embryos. embryos, according to the day, they will have so many cells. And when they reach the blastocyst stage, the embryologist will perform the biopsy. What I mean by that is at the blastocyst stage, the embryos will have 100 to 120 cells, and they will take 1 or 2 cells from the blastocyst. They will not take cells from the inner cell mass. You saw some clumps of cells inside. They will become the baby or fetus. But the outer layer of cells which were along the margin, they will become the placenta, and they will take 1 or 2 cells from that area. So you don't have to worry that, the baby will be damaged. We will take cells from the baby. They don't touch the inner cell mass which will become the baby. It is from the placental cells we take the sample. And then what happens is we send those cells to the genetic lab for testing of the embryos. Meanwhile, they will freeze the embryos in our lab. This is because it takes 2 weeks to get the results. We have to wait for the result and then plan the next step. So the next step is simpler compared to the first stage. Here, what we need to do is we don't have to worry about the ovaries. We need to prepare only the lining, which is done usually by giving estrogen tablets. Or if some people choose to have a natural cycle, they can also use their natural cycle, not use any medication. But using the medication gives a little bit of flexibility with arranging the embryo transfer time. If we have some patients who are very busy, if they can't do certain days, medicated cycle will be helpful. However, the success rate is the same with natural cycle or medicated cycle. Both of them should be monitored carefully. That is the important thing. And when the endometrium is thick enough, we will add progesterone to the treatment. That will be in the form of injection. And then when the lining is ready after 5 days of the progesterone injection, the embryologist will take the embryo out and we will transfer on the same day. Usually it's a blastocyst, and we'll wait for the blastocyst to expand nicely, fill with water. Usually when they are frozen, they are contracted and they are small, but we will wait for them to expand, fill with water, then we'll transfer them into the uterine cavity. Hopefully, next step will be the pregnancy test after 10 days, and hopefully we should have the good, successful result. 3 weeks later, we arrange the scan to confirm the pregnancy is in the right place, uterus and fetal heart is seen. It's a viable pregnancy. Everything is going well. And I know it is shown by 1 arrow here, but at least a long time, 9 months there, that is the gap there. And you will see your beautiful baby from this golden embryo. That's what we are all hoping for. One thing all the patients are telling me is the babies made in the Holly Street Fertility Clinic, they are not only beautiful, they are also well behaved. They tell me that the baby sleeps throughout the night. So all of you would like to hear that, I suppose. So if you have the golden embryo, you will have good, well-behaved baby as well as beautiful baby. So I hope you can understand all these steps now. If anybody has questions, you can ask us.
We have a video actually from a couple of our patients. They wanted to share a bit of their experience and how they went about choosing the embryo and how they got on with our staff in the lab.
Our family.
Our family.
Our family.
Our family. Our family.
No, we didn't know what to expect, to be honest, because again, it comes down to what we've heard from family and friends when they've done it. And they, a couple of our friends seemed like they struggled and they only got 1 or 2 viable embryos and only ended up being able to use 1 of them, for example. So we had that in the back of our heads.
Yeah, I think you were quite you were quite anxious to go through that process and see how many we could get.
I think just for anyone that does, like, there's certain things you worry about, like even when you're doing the injections to stimulate your body to get ready for the eggs, like we were like, are we doing the shots right? And, you know, obviously we got training, but you worried like, oh, a little drip came out. Did I lose some of the medicine? Is that going to affect everything?
The great thing with that is if you do feel like that, is that there were a lot of online tutorials that were helpful. And also we could just phone up and just speak to them. Or when we had our consultations were so regular that we had the opportunity to ask them, are we doing this right? This is what's happened. And they would always be really good at kind of just explaining, no, that's fine, or actually try it like this, see if that helps.
Yeah.
So yeah, even when there were moments where we were like, oh my God, what, you know.
And it didn't make a difference. Like for a couple of drops that, you know, you don't get from the needle didn't make a difference, because actually we ended up with 24 eggs. So it was a good number. It was a good number, and it was, you know, it made us laugh, because it's like, okay, just so you know, it's 24 eggs, but you know, the number goes down. We have to see how many are mature, and then actually 19 of them were mature, and they're like, okay, they may not all fertilize, but then 17 of them fertilize, and they're like, okay, the numbers will go down by the time you get to day 5. But by day 5, the blastocyst stage, we had 13 embryos that were good. So we were just like, wow, what are we going to do with all these embryos? And so it was one of those things where we had all these misconceptions or these thoughts just based on everyone else. And I mean, I'm sure their clinics have done a fantastic job as well, but we felt that because of some of the extra steps Harley Street took, as opposed to some of the steps maybe other clinics didn't take, it really contributed to how successful, at least for us mentally, it feels like it contributed to us having such a high number of viable embryos that were of really good grade. And then we were asked about the genetic testing, and we thought, again, if we want the very best chance of the embryo transfer to be successful, it's good to get the genetic testing to make sure all the chromosomes are there or none are missing, etc. So we did that step as well. And we had after that, Dr. Venkat got in touch to just make sure we understood what the results meant and what the next steps would look like for the embryo transfer. So yeah, it's been a very successful process. It's been a very enjoyable experience, because we weren't sure, just because of other people's not having been as successful. And
that's it. And I think at times it felt like there were a lot of appointments, there were a lot of scans, there were a lot of there was a lot of traveling back and forth. But actually now you realize that every single one of those things were necessary to make sure that we had the very best opportunity to get, as many eggs as possible to give us the best possibility of having, a strong, healthy child at the end of it. So it was definitely worth it, for sure. Yeah.
Oh, she's lovely, isn't she? I mean, we worked with Dr. Venkat, and then I'm going to say her name wrong. Dr. Leave. I can't. So she's a newer doctor that's joined from Belgium. She told me she's from Belgium, but she was fantastic. She actually started my process and ended my process. Dr. Leave, yeah. So she started it from.
We had an initial consultation with Dr. Venkat.
Oh, Dr. Venkat's been fantastic in terms of the initial consultation and then consultations throughout, just giving us more information about how everything works, what your next steps are, what your options are, even with sperm donors. So for us, being a same-sex couple, understanding, well, what do we need to be aware of for things like that. She was fantastic throughout, in terms of, and very knowledgeable, very kind, super smiley, which really helps. She's always energetic. Doesn't matter if it's 8 a.m. or 4 p.m. when we've had an appointment. She's always very ready to go.
Yeah.
Very enthusiastic, which really helps, because it's, she's probably done thousands of consultations, but she's just as happy when she does, she called us yesterday to give us about the genetics results, and she was just as happy then as the very first time. So yeah.
Yeah, she's brilliant.
Yeah, that lab, those amazing embryologists in that lab, the things they do, like working on the weekends, checking those eggs, those embryos, making sure, like I've gotten calls from the lab on Saturdays and Sundays. I'm like, these guys don't ever stop because those little embryos need to get watched, they need to be monitored, that's quite passionate to sit and, make sure that everything is working correctly and they're all growing correctly. And we were really happy that they kept, after the retrieval, the lab was great, calling me the next day and then on the weekend and then on the Monday, on the day 3, on the day 5. So it was nice to see that number come up on your phone because you knew you'd get an update on your little embryos and how they're doing. So it was
Who did you speak with? Sam?
So Sam a couple of times, and then another younger woman, I can't remember. Maya, yes, Maya. She emailed me as well. So Maya and Sam both contacted, each of them called me a couple of times, which was really nice. So yeah, it was good. I enjoyed it.
Right, I hope that video was useful and gave you a bit of a flavor for what you might expect if you're to go through treatment yourself. I'd like to thank Delia Carroll, our marketing manager, for putting that together. And then it leaves for me to open up question and answers, and some of you already popped in some questions to the Q&A box, and please go ahead and add some more if you have any more. I will field these across to our panel so that we can go through your questions. So the first one I have is, what would you recommend for a 42-year-old woman who doesn't have a diagnosis of diminished ovarian reserve, but has poor egg or embryo quality? And I'd like to pass this over to Dr. Venkat, if that's okay.
Yes, 42-year-old woman, we can check this ovarian reserve and quality. And then based on that, I would say it's important that we proceed with the treatment as quickly as possible. Understanding the chance of success is not very high. If we delay the treatment, it's going to be further lower. Therefore, it's important we get on with the treatment. And one has to go for the best treatment. I wouldn't waste time doing simple treatments such as intrauterine insemination. And some people ask me, my friend had Clomid tablets to, stimulate my ovaries, and should I try all that? No, when you're over 40, don't try simple things and waste your time. Time is of the essence. Go for the most effective treatment or most successful treatment, which is IVF. And at that age, I told you, the success rate is lower compared to a younger woman. But that's all we have. We have to go for the best treatment to get the best result out of the eggs we have got and the sperm quality as well. And I think that would be the best selected treatment under these circumstances.
Next question is somewhat related. It's clinical in nature as well. And it says, do endometriosis and fibroids affect egg quality? And does this effect change with age?
Yes, so there are two questions in this, two aspects in this question. Endometriosis is a difficult disease or is a nasty disease, yes. And nowadays we find that more and more young women are suffering from endometriosis. And endometriosis not only affects the number of eggs, it also affects the quality of the eggs, because the endometriosis, especially chocolate cysts in the ovaries, they secrete some chemicals which affects the quality of the eggs. And it is important that people, young girls who have severe endometriosis, they consider freezing their eggs so that they don't later on suffer. And yes, the answer to the first part of the question is yes, endometriosis can affect the quality of the eggs. And as everyone knows, the quality of the eggs go down or they deteriorate with the age, definitely. So the age factor as well as presence of endometriosis don't help the egg quality or the egg number. They are all, that is a double trouble, which is with the eggs. So there, people with endometriosis should do something as soon as possible. If they want a child and start a family, do it at your young age or once you are diagnosed with endometriosis. That would be my answer.
Thank you. The next question is more laboratory-based one. What's the reason for the cell mass to hatch?
Okay. So the blastocyst hatches. So surrounding a embryo is something called a zona pellucida, which is a bit like the shell. So for the blastocyst has to hatch out of the zona pellucida to implant into the endometrium to achieve a pregnancy. So the videos on the time-lapse show how the blastocyst herniates out of the zona pellucida to hatch, and then the next stages would be in the uterus to implant. So it has to hatch out of the zona pellucida to implant and achieve a pregnancy.
Thank you. So you're saying all our eggs are like chicken's eggs and they have to hatch out of the shell?
Yes.
Simpleton.
So the embryos to achieve a pregnancy, yes.
And you also help them with the laser arrestor hatching, Sam?
We can. So when we do PGT-A, we use a laser to make a tiny hole in the zona pellucida so that the embryo doesn't have to break through the zona itself. We give it a hole so it's easier for it to break through. And we also do this with frozen embryos, which, because sometimes the zona pellucida hardens when it is frozen. So therefore, we give it a weaker point that it knows it can break through and to achieve a pregnancy by implanting.
The next questions are somewhat practical. So it says, if you're 42, what is the BMI the clinic accepts? So as a clinic, we don't have a strict cutoff for BMI. Now, BMI is another factor that unfortunately negatively affects your success rate. If your BMI is over 30, it tends to impact the success rate. It makes it lower. But that doesn't mean you can't have treatment. We just need to make sure it's done safely. And most importantly, when you receive sedation, we need to make sure that's done safely. So if someone has a BMI of over 35, we request what's called an anesthetic review. We ask an anesthetist to review that patient to make sure that we can sedate them safely. But we don't have a strict cutoff on BMI. And the other part is how many embryos are transferred? As you said, it's only one for people under 35. It's not technically one for people under 35. We don't have a blanket clinic policy. The HFEA allows clinics to transfer up to 2 embryos in women up to the age of 40, and it allows us to transfer up to 3 embryos in women over the age of 40. And what's important is actually the age at which the eggs were collected. And so in someone under 40, we generally, or under 38, especially when we're doing PGT-A, because we would hope to have good embryo quality and hopefully the embryo would be euploid, we would advise them to transfer just 1. However, if someone has had multiple failed cycles, or we know that there's significant history and the patient has a poor chance of success, we might advise them to transfer 2 in order to improve their chances. Dr. Venkat, is there anything you wish to add on that?
Yeah, basically the number of embryos will depend on the age of the woman and the quality of the embryos, and also the past history. If they have had unsuccessful attempts somewhere else or here, we can increase the number to maximize the chances. At the same time, we counsel them about the risk of multiple pregnancy, which is not an ideal outcome. Even in women over the age of 40, if we test the embryos, and we tend to put 2 embryos, unless the embryo quality is not so good, or if they have had unsuccessful attempts before, in which case we tend to put 3 embryos.
And one more sort of practical question. Does embryo transfer take place on any day of the week, or what happens if the clinic doesn't do a transfer on a Sunday? How would this be handled? Again, Dr. Venkat, if I can pass that to you, please, on timing of embryo transfer.
Correct. So embryo transfer, we do frozen embryo transfer nowadays, because if you are testing the embryos, like I mentioned, we freeze the embryos, we wait for the testing results to come back, and we plan the treatment after that. So we arrange a follow-up consultation with the couple, and we plan the treatment. When we plan the treatment, we do the medicated cycle, and we take the embryos out on a day which is within a weekday. So it doesn't affect your success rate at all. We don't have to do it over the weekend. This is the advantage, because couples usually like to have it on Friday, so that we do it on Friday and they can rest over the weekend, Saturday and Sunday, and they can go to work after that, or if they want to take rest, they can take rest after that if they have some leave. So avoiding the embryo transfer over the weekend, it's not going to be a handicap for you. It is not going to reduce anybody's success. That is the one thing everybody is worried about. It is not like egg collection. Suddenly you will face a situation where you need to have the embryo put back, because this is a planned elective treatment, and we plan it, and then we give the progesterone, calculate the days. After 5 days of progesterone injections, then we plan to take the embryos out. So it is planned very well, and there is no problem in avoiding the weekends at all. In case of fresh cycle, if we have to do egg collection over the weekend, then if it is necessary, we arrange it specifically for that person. We will not fail to do that. But embryo transfer is not necessary during the weekend if it is planned well.
Next question is a very interesting one. It says the general trend is for greater likelihood of success with higher grade and higher quality embryos, particularly ones that are good quality blastocysts. Is this always the case, or can a high quality embryo fail to implant, but a lower grade embryo, otherwise euploid, surprise everyone and implant, resulting in a pregnancy? What can cause a good quality embryo to not implant? I'm going to actually ask all of our panel to add to this, but starting with Dr. Venkat, so I'm sure we're all going to have slightly different opinions.
Well, that is actually a very good question. This person who asked the question seems to be intelligent. I've done a lot of research on this. Yes, but usually we say, if you have a good embryo, you're likely to get pregnant. And that's why we call them good prognosis patient, because everything has gone on well with stimulation, decent number of eggs, decent number of embryos. And if we have done PGT-A also, we know which are euploid embryos. And if they are top grade like 4AA, 4AB, something like that, we are all hopeful, and we will think that patient will get pregnant. And sometimes the disappointment comes through. Some patients don't get pregnant in spite of this situation I mentioned. However, on the other hand, we have seen patients who have had average quality embryo, something like BC. So I must explain here, what do I mean by that? So the embryos, like Samantha was telling you before, the blastocysts are graded with number 1, 2, 3, 4, 5. That shows the expansion of the blastocyst. And then you have the letters, 2 letters, AA or AB. These 2 letters refer to the inner cell mass, that is the one which is going to become fetus, and outer layer that will become the placenta, that is the second letter. So it indicates the grading of these 2. So if something is 4AA, then it's the top grade embryo, 5AA is the top grade embryo. So the next comes the BB group, and then CC, DD. So A and B are good embryos, CC is average or BC is average, and DD is very poor. But in my life, I have seen a patient who had DD embryo along with BB embryos. And I said, have that BB embryo. She said, no, if I don't, put it inside, you are going to discard it. I don't want to discard my embryo. So I will please put that one also in. So we thought, okay. And she was a young person, 35 or 33. And so we put BB and put DD, both the embryos. And you may not believe this. She ended up with twins. And so both the embryos, DD as well as BB, gave baby there. And we were all surprised to see that the poor, I should not say poor quality, average quality embryo gave rise to a baby. So it can happen sometimes. Then that's why I feel sometimes, people ask me, why do you believe in God? This makes me believe in God, because even though we do all this, so much scientific thing, there is no answer to this. We do not know, or there is no explanation as to how this embryo implanted, how some of the AA embryos don't implant. So that is the big question mark. So there is a mysterious power behind all these things. That's my answer to it. I'm happy to hear what Samantha has to say.
Thank you, Dr. Venkat. Yes, we see, I don't, same as Dr. Venkat, I don't know why sometimes you get an AA embryo blastocyst that doesn't implant, and you could get a CC one that achieves a pregnancy. We see quite frequently when we biopsy that an AA grade blastocyst may come back as being aneuploid, so abnormal, and a CC may come back as being euploid and normal. So it's really hard to predict which embryo is going to achieve a pregnancy. We obviously tend to replace blastocysts back in the order of quality. And sometimes people don't achieve a pregnancy with the grade AA, but they may achieve pregnancies with subsequent cycles, putting back grade BBs or BCs or CCs. It's really hard to know. There could be other factors. There could be factors such as, I'm sure Dr. Venkat will elaborate in a moment about things of timing to do with endometrial lining, maybe not totally in sync with the time of transfer. And there are tests that Dr. Venkat will talk about to do with that, or there could be a variety of reasons.
Yeah, Sam, thank you for that. I would like to add what Sam has mentioned there. She's right. Sometimes we don't put the embryos at the right implantation window, it is called. So generally we say the standard implantation window is after 5 full days of the progesterone, and the 6th day is supposed to be the standard implantation window. However, the research shows that some women have implantation window deviated to the normal one or the standard one. They can have the implantation window 1 day later or 12 hours earlier at different times. In which case, if I replace the embryo at the standard implantation window, it may not be the right time for that woman and implantation may not happen. In such cases, we do the test called endometrial receptivity assay. It's called the ERA test, where we take a biopsy and then study the cells and tell us whether this implantation window, this biopsy time is at the implantation window for that woman. And, or if it is not, they will tell us when is the right implantation window for that woman. Then we can plan a personalized embryo transfer for that woman at that time, at her time of the implantation window. So that is one of the reasons for the embryo not implanting. But there are also other factors like immune factors, which a lot of people talk about. And of course, a lot of people don't like this. Even our regulator, Human Fertilization Embryology Authority, don't support this. But in a practical life, we have seen lots of patients having multiple cycles of treatment in other clinics, coming to our clinic And then we do the investigations like this implantation window and also this immune testing. We test for blood clotting factors, autoantibodies, and natural killer cells, and Th1, Th2 cytokines. These are all immune modulating factors which can affect the embryo implantation. Somebody has got a high level of antibodies, they go and affect the embryo. Basically, in layperson terms, they kill the embryo and prevent them from implanting. Similarly, if the blood clotting factor is affected, there could be blood clots in the placenta, reduces the blood supply to the fetus or embryo before even it implants, or after implantation, it can result in miscarriage. So like this, there are other factors. And similarly, there could be some uterine abnormality. Like if the uterus has got a septum or something like that, or uterus is abnormal shaped, biconvate uterus. Today we did a hysteroscopy in a woman. When we did a scan, it was not very clear, but there seemed to be a shadow in the middle of the uterus, which looked like it had divided into two horns. So when we did the hysteroscopy, we found that she has got a septum in her uterus. If I put the embryo in such a uterus, the septum doesn't have much blood supply. So embryo will start implanting, but it will fail because of lack of blood supply. If this diagnosis is missed, then embryo will not implant. So there could be other factors which interfere or prevent the embryo implantation and reduces the chance of survival of the embryo and becoming a fetus.
I think the other point actually I'd like to add to all of this is, embryo quality and even testing for the right number of chromosomes doesn't tell us the whole picture of the embryo. There's, an embryo is enormously complex, and there could be small genetic abnormalities inside of it that we're not picking up that could cause it to fail to implant, or it could miscarry as a result of it, or it doesn't interact well with the endometrium. So we haven't got the whole picture yet, which is why our success rates are where they are. Hopefully, and when we see these success rates slowly creeping up, and when we get to the point of 100%, we'll know what causes an embryo to always implant or not implant. We're not there yet. The science is still in progress, but it's getting better every year. Next question is also a good one. It says, when ICSI needs to be done, how many eggs are inseminated with the sperm? Do you try to fertilize them all once the eggs are thawed or stripped, or only one or two at a time? I pass this on to Sam. That's it.
Okay, thank you, Suvir. So we will inject performing ICSI on all the eggs that are mature. So when we've collected some eggs and we take the cells off or strip the cells from the outside of them to see how many are mature, we usually inject and hopefully achieve fertilization in everything that was mature that we can. That is the usual procedure. Obviously, some people, if they had a large quantity, may not want all of them injected, or in the cases where the sperm count is really low or has been surgically retrieved, we may struggle at times to find enough sperm for all the eggs. So therefore, if that was the scenario, we could always freeze some of the eggs so that they're not wasted. But usually we perform an ICSI on every egg that is mature.
The next question that we have is, if you have a day 3 grade 1 8-cell embryo, is it best to wait until day 5 before transfer? Sam,
that's a good question. So we tend to use the Association of Reproductive Scientists grading system in the UK. So we don't use grade 1 anymore. So our grade 1 would be the lowest quality and grade 4 would be the top quality. So I'm going to assume that you're talking about the top quality embryo. You can leave, if it was just one embryo on day 3 that was the top grade, you could leave it to day 5. There would be a slight risk that it may not achieve the blastocyst stage. You could say that it doesn't achieve the blastocyst stage because there is probably something within that embryo that isn't quite right. And therefore, that's the reason it has stopped growing. But if you can get a blastocyst stage embryo, then it has a higher chance of achieving a pregnancy. So usually we would say if somebody has 3 or more top grade embryos on day 3, they stand the chance of achieving 1 or 2 blastocysts on day 5. So it would be a decision made by Dr. Venkat, the patient, the laboratory team, as to whether somebody is willing to take that risk. You could say that if an embryo stopped and didn't make it to the blastocyst stage, that devastating as it is, at least you know then that it probably wasn't going to achieve a pregnancy, as opposed to putting a day 3 embryo back and maybe it not achieving a pregnancy after you wait 14 days to get a pregnancy test result. It's a situation where all of the team and the patient would be involved in making the decision. But usually we would try to take most embryos to the blastocyst stage.
Next question, if you have time-lapse treatment, does that mean you can't have fresh transfer? So no, time-lapse is just essentially it's the incubator technology that we use to monitor the embryos as they grow. And you can have a fresh transfer after the embryos have been in that incubator, the same way as if they were in a conventional incubator. You can't, however, have a fresh transfer if we do pre-implantation genetic testing, because it takes a while to get the analysis of the embryos performed. So if you're going to have PGT-A performed, you would need to freeze all the embryos, wait for the genetics results, and then undergo the frozen embryo transfer. Next question is, how long does the whole process take from start to finish? And if one's egg reserve is not great, but due to circumstances, one cannot proceed immediately with the whole process, what can be done to sort of, I guess, mitigate the impact of this situation? Dr. Venkat, if you wouldn't mind answering this one.
Well, I mean, when you say we can't do much, it's not very clear to me that you are not able to proceed with IVF treatment and freeze the embryos and test the embryos. If that is not possible, and if there is a problem in proceeding with the treatment, and if you want to avoid problems in future, another option would be freeze the eggs if the male partner is not available or sperm is not available. Because I have a patient whose partner has gone overseas, and because of the COVID, he is not able to come back here. And she's 41 and a half. She's nearly going to become 42 in another 3 months. And her ovarian reserve is not great, not ideal. And she's in a quandary now. She said, oh, shall I wait for him to come back and do it? Or what shall I do? She actually waited from January thinking that he will be back. Now it's already March, nothing has happened. And then I told her, look, why don't you freeze your eggs? And I know freezing the eggs is not the ideal solution here at this age. However, it's better than doing nothing. Freeze your eggs, and then because the ovarian reserve is low, when the partner comes, you can do another round and you can take out the frozen eggs, fertilize all the eggs together and do the treatment. So that is the option I gave her. Similarly, I think we have to settle for egg freezing under the circumstances. If you cannot do egg freezing also, I don't know what else I can suggest, because the time, the aging process, the nature takes on, and we cannot stop the nature from doing its job. So that is a difficult situation there.
Just as an option in that circumstance where someone is abroad, could we not consider freezing his sperm and shipping it to us?
Yes, we discussed, but he's in a country where, things we are not sure whether they are registered. As you know, the Human Fertilization and Embryology Authority have strict guidelines saying that those laboratories or the clinic should be registered with the accredited, bodies. ISO or ISO accreditation should be there. Only then we can import those gametes. And then this is going to be a problem in certain countries where they don't have strict regulations. What do you think, Sam? Because you are the expert in import and export.
Thank you. Yes, it can be difficult from certain places. It depends what country's in. Perhaps, we need to look into that for her. But it could be possible in the majority of countries, I would say, we would be able to import.
Next question says, are chances of success getting higher with fresh or frozen embryo transfer? Dr. Venkat, if you wouldn't mind answering this.
So what is the real question here? Which is better or
yes.
which is increasing? What is the question?
I think the underlying question is essentially which is better.
Yes. Okay. So the fashion changes, the thoughts change, and the technology also improves, and the things which were sort of recommended some 5 years ago, 10 years ago, because I have said in the past, fresh transfer is always better than a frozen transfer. And we have recommended always fresh transfer if somebody can have fresh transfer. Frozen transfer is only under circumstances when somebody has hyperstimulation, she cannot have the embryo put back. Otherwise, everybody used to have fresh transfer some 10 years ago when we were doing IVF. Sam will agree with me.
Yeah.
But nowadays, as technology has improved, the freezing techniques have improved. Previously, we were freezing by slow freeze technique, and now we are freezing by vitrification. That's called rapid freezing. And this is supposed to be a better system, and more embryos and more eggs survive this freezing technique. And the success rates are much better with frozen embryos. Therefore, now the success rate with frozen embryos are better compared to the fresh embryos because of other factors as well. Because when one undergoes stimulation, the hormone levels are high, the tummy is bloated, the ovaries are enlarged, and her body is not in a fit state to accept the embryos. So it is better for that woman to recover from the stimulation process, allow her some time, and she can have the embryo put back in the next month. Therefore, the embryo is frozen and transferred in the next month. And because the success rate is very good, and we say we do that, and because her body is also in a better condition, on the whole, the success rate is much better than the fresh transfer nowadays. So now the recommendation is to go for frozen embryo transfer. In addition, the babies are supposed to be healthier after frozen embryo transfer rather than fresh transfer.
Okay, and the last question that we have is, how long are frozen eggs viable for? Sam, if you wouldn't mind answering that question.
Okay, so frozen eggs and frozen embryos don't deteriorate once they're frozen. Okay, so they would, in theory, be viable for a long time. Under current regulation, we can only store frozen eggs for social egg freezing up to 10 years. And we can then store frozen eggs for people who are prematurely infertile. So that's people that have had oncology treatment for cancer, maybe, or it could be for other reasons. We're allowed to extend that past the 10 years, but for social egg freezing, we're only allowed to store them for 10, but the viability could be for as long as you want at the moment, so they don't deteriorate once they're frozen.
I think I'd like to add, there is actually a bit of discussion and a possible consultation about extending these periods. So the periods are set by the regulator, the HFDA, as to how long we can keep eggs, sperm, and embryos in storage. And they're considering extending the 10-year limit on these. At the moment, actually, they were extended for during the lockdown for 2 years. So clinics could store samples for up to 12 years. But as Sam said, technically you can keep them indefinitely. And those are all the questions we had. So I hope that's been a very useful and informative webinar. I'd like to thank all of the audience for attending, and I'd like to thank our panel for their time this evening and all their information that they've provided. It seemed to be quite a fruitful discussion, and all that remains is really to wish you all a lovely weekend, and thank you again for attending. Have a good night.